not to confuse with other type of malignancies. In some areas of angiosarcomas, you don't have any vasoformative structures, so you could just say that it is a high-grade sarcoma. Sometimes, just like in our case, there might be some epithelioid appearance resembling carcinoma. If you have a small biopsy, here is the superficial skin and the epithelioid sarcoma extending into the dermis, and these also mimic high-grade carcinomas, just like we were confused in our case. And for many years, there was a considerable research effort to classify angiosarcomas based on grading. And there were many grading criteria to classify angiosarcomas based on nuclear features, based on papillary formation. But now we know that histologic grade really does not correlate with clinical outcome. Because of that, we really are not using the grading system. So we make the diagnosis of angiosarcoma. You can indicate high grade, low grade, predominantly for identification of the lesion later if there's a metastasis or there is some additional lesions to identify the lesion, but from the prognostic point of view there isn't really any significance. And if you use any of the published criteria, usually the grade distribution is pretty evenly spread between low-grade and high-grade lesions, and intermediate grade lesions is usually the least common type. But again, these lesions show significant variation from one area to another. So you have to make sure that you did the evaluation extensively so the grading reflects the entire tumor. And when we look at the outcomes of our patients, great majority of the patients develop distant metastases, and when distant metastases occurs, the prognosis is usually very green. And this is one of the most extensive studies published regarding the grading. And as you can see, the grade really does not correlate with the outcome. And based on other studies and based on this, now we are not using grading. Epithelioid angiosarcoma is our case would be classified as is a lesion described as an aggressive neoplasm, frequently mistaken for memory carcinoma. So when I am looking at corneal biopsies, when I have a high-grade lesion without any ductal differentiation or any specific morphology that I can identify as definitely primary breast carcinoma, angiosarcoma, even though it's a rare lesion, it's always in the back of my mind. So these patients, especially the epithelioid angiosarcomas, a lot more common in patients with radiation therapy. Here is another example of epithelioid angiosarcoma. As you can see, when you have small biopsy, these epithelioid tumors could be mistaken for carcinomas. In terms of differential diagnosis of low-grade lesions, we have a number of benign vascular lesions that could be separated from angiosarcoma. And among these lesions, probably the most important one is the atypical vascular proliferation. The other end of the spectrum, the high-grade lesions, carcinomas, as I indicated, is an important thing to exclude, other sarcomas, and one other lesion that really always in our differential diagnosis is metastatic melanoma. As we all know, melanomas can mimic any lesion, and so when we are doing our panel of immunohistochemistry markers in a high-grade lesion without a definitive differentiation, we always include melanoma markers. Hemangiomas, most of the time it's an incidental finding. They do not form a mass. Very rarely, if they are biopsied due to predominantly for MRI abnormalities, these lesions are easy to recognize and they lack endothelial proliferation or atypia, but as I indicated before, the most important thing is lack of anastomosing channels. So these are individual vascular spaces without any anastomosis. And sometimes the low-grade angiosarcomas mimic these hemangiomas. Again, this anastomosing feature is very important. This is a core biopsy of a lesion, and you can see these vascular spaces containing red blood cells. Again, it's very bland looking, and so this is an angioma. Angiolipomas have been described in breast, and they are very similar appearance with angiolipomas occurring elsewhere. And most of them occur in subcutaneous tissue, not in breast parenchyma. This is an example of angiolipoma occurring in subcutaneous breast skin. So again, these lesions are small blood vessels, lack of anastomosing, and majority of the time, if you have the entire lesion, they are well circumscribed, they are not infiltrative. In small core biopsies, the myofibroblastic stromal proliferation patch can be in the differential diagnosis, but again, these lesions are quite bland, and most of the time we identify these lesions, and if they are large and appear to extend into the lobular units, we can always do immunohistochemical markers to see if they are vascular or stromal. The main differential clue on benign lesions is the dissection through the normal structures and this anastomosing growth pattern. Cytologic atypia, if it is there, it's helpful, but if it is not there, it won't exclude malignant lesions. When we are working up these vascular lesions, just like any other lesions, we have to do a panel of markers, and vascular lesions are positive for CD31, CD34, and recently the nuclear transcription factor ERG is more commonly used, and IHC is only necessary for characterization of poorly differentiated tumors. If you have clear-cut vasoformative areas, most of the time we don't need to use immunohistochemistry. Both CD31 and CD34 are commonly used. In general, CD31 is more specific but not sensitive, and CD34 is more sensitive but it is not specific. And we have to always remember that both of them can be expressed in the intratumoral macrophages. So especially if you have a small biopsy and then somebody is showing these few CD31, CD34 positive cells, you have to be cautious interpreting that. ERK is a transcription factor that regulates angiogenesis. Now it's a sensitive and relatively specific nuclear marker for endothelial differentiation, and we very commonly use that. And the other tumors that are positive for ERK include prostate carcinoma, AML, and PNAT. But usually these lesions are not in our differential diagnosis when we are looking at breast vascular lesions. As I indicated before, lymphatic versus vascular etiology of these tumors has been evaluated in the past extensively. So for that, different markers have been proposed, but again, it doesn't have any clinical or biologic significance, so we don't use it. From immunohistochemistry, we have to always remember that aberrant cytokeratin and EMA expression can be seen in vascular lesions. Usually it is weak and focal. That was the case in our core biopsy. And weak and moderate patches staining has been reported up to 25% of angiosarcomas. So one focal keratin positivity does not make it into carcinoma. When we are evaluating the high-grade spindle cell lesions of breast, we are thinking of spindle metaplastic carcinoma, and they also can show focal keratin positivity. And that, in that case, the marker that we are using is P63, and it's isoform P40. And so these have been used in the clinic to make the diagnosis of metaplastic carcinoma. And here's an example of metaplastic carcinoma. But I personally have not seen an angiosarcoma with P63 staining, but it has been reported in literature. So again, P63 alone does not make the diagnosis of metaplastic carcinoma. Breast epithelioid angiosarcomas also can be P63 positive. If we are thinking of metastatic neoplasms, we have to use a panel of markers. And here's a metastatic melanoma in the breast, and it is keratin negative and MARC1 positive. And on these metastatic tumors, more than the immunostaining, clinical history is very important. So I always say the most important staining on these things is a phone call to the clinician and find out if the patient has any primary tumors. So the message from immunohistochemistry is that always use a panel of markers. Don't use only a single marker, and don't make the diagnosis based on focal staining of either cytokeratin or P63, because these can overlap with breast carcinoma markers. The other differential diagnosis that I mentioned is the atypical vascular lesion. These lesions occur after radiation therapy. They appear as a small pink nodules, and here is a clinical presentation. As you can see, it's a large area involved with these red nodules. It is not as extensive as the angiosarcomas that I showed you, but that is the main clinical differential diagnosis. When we do the skin biopsies, there is a vascular proliferation. Dissection through the collagen is commonly seen, And when we look at the vascular spaces, we are looking for, again, inter-anastomosic spaces. In general, these atypical vascular lesions are described as having branches and these atypical contours. So I personally have very difficulty to separate branching versus inter-anastomosing. So even though we say that the benign lesion should not have anastomosing vascular spaces, this branching feature of a typical vascular lesion is, in my opinion, very difficult to separate, and I always have a difficulty on that. Higher magnification, showing that you can most of the time show the stroma between these vascular spaces, and more importantly, these are lined by single layer of cells. Usually you do not have any endothelial proliferation, you don't have the protrusion of the buds or small papillae into these spaces. Sometimes you can see these individual nuclei protruding into the channels, but you don't have the proliferation, and you don't have erythrocyte extravasation into stroma. But I should caution you that these lesions are difficult, and if they do only punch biopsy, and if you have only small focus of lesion, they can mimic angiosarcomas. So when you look at the clinical features, they are usually small lesions compared to angiosarcoma. They usually occur within the 3 to 4 years after radiation. And more importantly, we have to separate these things from angiosarcomas because these are benign lesions. Although few patients have been reported to progress to angiosarcoma, great majority of these lesions are benign. And some people feel that they may represent a morphology continuum, this being the most benign spectrum of malignant vascular lesions. Again, although all these features have been looked at and described in the literature, it is not very easy to separate these lesions, and there's a significant overlap. And when we look at the markers, again, there's a significant overlap. The only marker that can be reliably used is the MYC protein expression or amplification, which is very commonly seen in angiosarcomas, but atypical vascular lesions are typically negative. So this is what I personally use in clinical practice, the MYC amplification. This is a report published a couple years ago, and the both protein expression and the gene amplification is the most reliable method to separate these lesions. In terms of treatment of angiosarcoma, the most commonly mastectomy, and if the tumor is large, the chest wall resection is the most curative therapy. There are some targeted therapy options, but we don't have extensive experience with these. And the only chance of curative treatment is the adequate surgery. Most of the time, these lesions do not metastasize, although metastasizing in the axillary lymph node has been very rarely reported. The axillary dissection is not indicated. So in conclusion, angiosarcoma is a rare malignant neoplasm of breast. It is seen increasingly frequency due to increased incidence of breast cancer and use of breast conservative therapy. Low-grade tumors are challenging because of their deceptive bland appearance, and high-grade tumors are challenging because of their resemblance to high-grade tumors. Thank you very much for your attention. I guess we are not taking the questions, right?
Thank you, Professor Aziza. Nice talk. Now, Professor Dr. Decia, then you divide, Associate Professor at the Department of Pathology, District Medical Center, Harvard University. She will give us talk about biphasic breast lesions, differential diagnosis, and the diagnostic challenge.